We would now like to start our session on healthcare simulation, need of the hour. Medicine and nursing has traditionally relied on a see one, do one approach of learning, which inexorably exposes patients to novice, inexperienced, and hyper-skilled healthcare practitioners, with resultant dangers and harms, adversely impacting patient safety and consequently clinical outcomes. Healthcare simulation is a pedagogy to replace or amplify real patient experiences with guided experiences, artificially contrived, that evokes or replicates substantial aspects of the real world in a fully interactive manner, thereby helping each healthcare professional to be patient ready for providing a high level of patient care. Debriefing session following the simulation activity helps in promotion of reflections of the participants and remains the heart and soul of simulation activity. This session focuses on need and role of simulation as an educational strategy for providing the opportunity for learning that is both immersive and experimental.
To elaborate more on the advantages of healthcare simulations, I would like to invite Surgeon Commodore Dr. Manish Honwad and Mrs. Abra Pearl. Dr. Manish Honwad is the Senior Registrar at INHS Asvini, Mumbai. Sir has specialized in anesthesiology and was a professor of anesthesiology at AFMC Pune. Dr. Manish also has numerous publications in indexed journals. Sir has served as a flight surgeon on aircraft carriers and commanded the INHS Sanjeevani at Kochi, Kerala. I request Thank you, Dr. Manish Honwad.
Mrs. Abra Pearl serves as a consultant to the Indian Nursing Council, Government of India. Ma'am is a master trainer in skill standardization and simulation training and has an experience of over 15 years in nursing and midwifery education and public health. Ma'am has helped establish several national nodal centers for nursing and midwifery education in India. I request Mrs. Abra to grace the dais. Thank you, ma'am. To initiate the proceedings, I would like to hand over the mic to Dr. Manish Honwad.
A very good morning to all of you, ladies and gentlemen. And Pune is my home base. So I must, at the foremost, thank the organizers of this conference for having invited me for this talk. And I'm also fortunate to have a co-chair. So if I miss out on something, I'm sure she'll cover it up. And over the next probably 1 hour, we are going to speak on the importance of simulation. And why it's taking on in a big way, and I'm sure this is a mixed audience, so I've added a lot of videos in the middle to keep your interest. And can I have the first slide, please? I'm the Senior Registrar of INHS Asvini in Mumbai. We are a 1,000-bedded tertiary care hospital, and we have all subspecialties and post-graduations, including nuclear medicine, radiation oncology, hyperbaric medicine. We have postgraduates in all specialities. We have a College of Nursing and an Institute of Paramedical Sciences where we have a simulation center. I have also been in touch with Symbiosis earlier during my tenure at AFMC when we conducted combined workshops, and we have a lot of role in faculty development in simulation where we have a sort of a national faculty where we take on BLS, ACLS, ATLS. So I'm quite aware, and also it's a proud privilege for me to come back and meet my senior colleagues from AFMC who are here at SIHS. And so before much ado, I'll try to move on to why simulation is the need of the hour. This is the way I'll propose to complete my talk. It all began here, way back, when doctors used something called personal digital assistants. These were the first black and white devices which came on, and most of these were used by doctors way back in the US, where most of these were held. And most of the medical software was written on them. It was a much better system called Palm. Unfortunately, Palm was killed, like how the Palsicam was killed by the VHS and other things. But then way down, this was most of the doctors have used this at some time or point in their lives. Even today, using a third-party software, I'm able to use some of the simulation here. Like for example, ICU maths, ventilation. If I want to change the ventilation parameters in ICU, I can still calculate. And it does not crash like Windows, or it does not have any other issues. Unfortunately, it is no longer available. It is still available to a small niche of people who like to use this. So actually, let me say that screen-based simulation started off with these palm tops, so-called. And most of the palm tops were used by the doctors. And the precursor to simulation was aviation. Just like safety in medical branch and medical sciences has, learned from aviation industry. There were a lot of aviation accidents way back in the 1960s and 70s. And it was thanks to Boeing and so many other flight simulators and their checklists where they brought down and made flying as safe as possible. Similarly, those principles of simulation were taken from the flight simulators and they made human patient simulators, various types of things, and brought in these things so that we could introduce safety. Not only that, it was skill-based learning and team building. How do we do it? I'll just show you what happens here. Just watch this as so this is a moving platform, the MiG-29, which is actually Vikramaditya. I use the Russian version of it because for security reasons I can't push the other one. But how is this possible for a pilot to be so to do it so well and error-free? Is because he learns on a flight simulator. He has to do hours on a flight simulator, pass it, and then come back. Now, the same thing in medical simulation, the definition is of course there, but no longer is the time when you can probably go and practice on a guinea pig, who is a human. So therefore, you must go to the sim lab, practice all your things, gain some sort of an experience before you go on to the real patient. That is number one. Number two is errors. There are many ways in which you can, master certain skills. I'm an anesthesiologist. I work in the OT and ICU. There are many such skills which I have to impart to my students. With overgrowing curriculum, increased course curriculum, and less time that we have, we need to do just-in-time training and ensure that when somebody passes out, he or she has gained basic minimum qualification criteria. The must-know has to be known. So how do we do that? We have to have simulation incorporated, not at the end, right throughout the medical curriculum. So that first stage, second stage, third stage, right from anatomy to when you become a surgeon or subspecialty surgeon, or you're building your team in cardiology lab, cath lab, you need to work with the entire team in a simulation center so that you don't make errors when you're actually doing that with the patient. There are three types of domains: cognitive, psychomotor, and affective. There are a lot of educators over here also, I guess. So basically, based on best standards of care, error management, patient safety, patient autonomy, and resource allocation, all these are important when you're deciding on a simulation center. You may have a simulation center, but you need simulation educators. You need educators who are qualified, who are ratified to ensure that at all levels they teach, they change your personality. By the time from a medical student or a nursing student or a paramedic, you pass out, you have to ensure that this particular person has changed his personality to what we desire. So here in simulation, we have immersion, we have immersive simulation. There's a lot of reflection and feedback. It is not just a skill learning process. Many of them think that, okay, you're learning laparoscopy, go on the simulator, work on it and come back. No, I'm building my team in the OT. I have to practice my emergency. So I have to build and have role play. We have to have, it's a multidisciplinary approach. We have doctors, we have nurses, we have paramedics, we have everybody, and we give the scenario to them. We role play the thing in actual. It's possible with simulators to do the whole thing. And then every specialty, everywhere, there is a role of simulation. Even forensic medicine, learning pharmacodynamics or pharmacokinetics of a drug can be done using simulation. Whether you want to portray anything in ICU, OT or this thing, there is a role for simulation in every place. The fidelity changes. You don't need high fidelity for everything. You could have part-task trainers, you could have low, medium and high fidelity trainers to do your job. What are the advantages? No harm to patients. You can allow errors to occur. It's a realistic experience. Some of them, in fact, I'll show you some videos in which we'll do this. Managing rare and uncommon situations. We have a rare disease, I can recreate it in real virtual 3D simulation. So suppose somebody has never seen this case, he need not see the case. He can actually do the simulation and he'll be fully confident in dealing with it when it comes. There's no trial by chance. Procedural skill training. I do a lot of regional anesthesiology, and when ultrasound came into the thing, it was first the radiologists who learned ultrasound. I learned a lot of ultrasound on simulation, and it's really realistic. There's no problem. We have hardly have. In fact, I stopped using the electrical stimulation for anesthesia. I was using ultrasound for the last 10-15 years, and there's no problem at all. Because of anesthesia, I learned all my videos and all on simulation, and it's very good. Everywhere where I can give a block, I give a block. And even my students, they learn it so fast. Whether it's airway management, intubations, and using the ambuscope, using, with the TB coming down and oncology, passing double lumen tubes used to be a real art. And people used to have, you require a lot of time and cases when you master passing double lumen tubes. But having real-time simulators, I have a simulator in FMC where, I teach students, everybody in my student, by second year, they can pass a double lumen tube on the simulator very well. and you can grade them, you can see how good they are in it, and you can do team building. So knowledge, skills, and attitude will transform into efficient clinical care. I put this for regional anesthesia because that is where in my domain it catches, but for the cardiologists, for the nursing staff, for the paramedical staff, everywhere. Remember one thing, somebody will not do a CPR in an emergency, there's a collapse if he has never done it before. And if he has done it on a simulator, it is more likely that he'll try it out at least. So therefore, I think as a citizen of this country, all of you must know basic life support. Seattle is the world capital of CPR. Nobody will let you die there because every citizen over there knows CPR. Similarly, we have reached a stage where we have started teaching CPR in schools. So anybody above 8 standard, where they have enough weight, they are about 35 kg, so they can deliver effective CPR. And I think Dr. Savant is here and people from SYHS, Dr. Parag, we have actually done a lot of workshops in Pune zone. And I think in Maharashtra came one of the top when we are trying to train most of the students in medical colleges. So every student comes out with at least BLS and ACLS. That is the doctors and nursing staff, and paramedics do the BLS at least. And everybody should know ATLS. Those who are in this niche, especially those of the clinical specialties, because this is a must. It's a must know. Then there is something called need to know and desirable. So these you need to know, and then you need the simulation lab. You have to fall back on the sim lab for everything. We opened up it as a game. In FMC, the simulation lab was, well load, you need to log in, log out. We said, no, we'll push it down where the students come to play badminton. So we got a whole floor, it's like a mall. And we put one clinical tutor and 2 of them there. We said, come and practice intubation, come and practice IV, come and practice part task trainers, and come in the own time, evenings, because the new generation doesn't want to stick to your timings. And we made it like a game, come and make errors, come and have fun. We'll have a team and you make the emergency. You make the emergency where the tube is in the wrong place and give the relaxant, and then suddenly the saturation falls. So this is what simulation we do, and others have to do it. There is a precaution here, yes. As a simulation educator, many of you are professors, you will be educating them. You must remember you are working with interdisciplinary teams. And even today, if you say I have to appear for an exam, I will have something in the back of my mind. So even sometimes, the first time we did the simulation, I have incidentally done my simulation education from D.Y. Patil. And at that time when we were working, we had senior professors. They were mostly from anesthesia and pediatrics, but we realized we have senior professors, senior nursing staff who were literally matrons of hospitals. We were doing the simulation together. Nobody wanted to make an error. You are being recorded and you are going to be debriefed after that. What did you do? And it's played back to you. It's played back to you and you sit around in a circle and you're trying to say what went right. How did it go? What went right? What went wrong? What can you do better? These are the 4 common questions which you ask. And you try to go into it and actually you learn. And this sort of immersive learning that you have with a team, that leads to the actual outcomes. And it is for the person who's designing the simulation to find out what outcome he wants. Sometimes it doesn't go the way he wants it, but then the educator, he's able to process it in a way that the learning outcomes are achieved. So again, the CRM skills, I think madam is there, so I'll not eat into the time. Undergraduate training, this is what you do. You do just-in-time training. And, adults have to unlearn habits. Sometimes they do things wrong, but children don't have it. So basically, when they come at the undergraduate stage, they absorb whatever you're telling them. But the moment there's a dean or a professor and he's already a thing, you tell him, no, you're doing this wrong. They don't like it very much. Sometimes we've had problems with protocols and we've had fights in the simulation centers. We've had people crying when they come out of the simulation center because, so you have to maintain this. So first of all, we tell them, there'll be a first year resident and there'll be a professor who's 30 years of experience and you're working together. So first of all, ego goes out of the window. So we said we are like anesthetists, we are wearing the scrub suit, there's no rank, there's no rate, you're not anything, you're coming here into this and you're allowed to make mistakes and you do as per protocols. You learn your protocols early. We're not here to learn protocols. We tell them, you learn your ACLS, BLS, ACLS, your algorithms, you should have them. What we are doing in simulation is doing the final team building. That is where high fidelity simulation counts. PG training, yes, implementation of certain things. This is what we do. That's flashed on the slide. CME training, there's so many others. I think with shortage of time, I can't cover all. It's a mixed audience. So maybe what do? We need to have a mix. We need to have a mix of part skill trainers, high fidelity, simulated scenarios, virtual reality. Now we have 2D to 3D. And with many things coming up, augmented reality and all this, I'll just go in the next slide. I'll explain what I mean about this. Because everybody says machine learning, artificial reality, what is it actually? So I think like Windows for Dummies, I'll tell you exactly for dummies what it is in just about 5 minutes. This is disaster management. Simulation plays a lot of role. This is an actual air crash at sea, which we simulated. We had an Air India, imagine a passenger flight going to the sea. So this was a tri-service exercise which we did, in which we actually had 150 of our naval divers into the sea. I picked them up after 4 hours. And we had to get them back. This was off Chennai somewhere. We were not told where. So Air Force was supposed to find out where it has crashed. And we were supposed to go as a hospital ship, get all the patients back and move them in. And we actually did this. We did the rescue, we picked them up from the boats and got them bound. This is how it happens on ships. And we have an emergency operations theater. Everything is actually simulated in actual. It is not possible to do it. Today, we can do it in simulation as a tabletop exercise. I don't need to put people at risk, but sometimes in military, we have to do it. But many such scenarios can be done. One such scenario is disaster management, which every hospital needs to do. The first time you do it, it will be a disaster when you do a simulation that I'm saying. Because everybody doesn't know where his action port is, how they are supposed to function when suddenly you have a truckload of people coming mangled up. But the first time you have done it, the second time it will be much better. Now moulages, we use things. So you can see it looks quite grotesque, isn't it? But this is, we have variables today and you can simulate an injury. So this is actually, nothing has happened to him. It's thanks to my cooks and their ingenuity of my artists. They use poster colors and everything to design this. And suddenly my surgeon, who was my CMO, boss in Cochin in Kerala, so he actually told the cooks, just make these guys ill. And we had told them, there'll be an exercise, but we never told them what time, where. We had warned them, but we just sprung upon them what you'll do. And then we observed and recorded what all they're going to do. So that element of surprise was there, the element of backup was there, and you see how realistic it looks. So it doesn't require a lot of money to do it. It requires your innovation and jugaad to actually get the moulages. And nowadays you have, of course, CA has got those things you can actually operate. You can do a appendicectomy, you can do a cholecystectomy live wearing a wearable. I have the videos, but time constraints, I can't do it, but I will share it with SYHS. So some of the students can actually see how on a cut suit, you can actually cut open a guy and, with a wearable and actually do a surgery in virtual simulation. So what are the things? One, first is, there are various outcomes you're looking at. This is for the educators. We're looking at a behavior change in simulation. When you're doing team building, you're doing it learning and of course satisfaction at the end of it. It's like a lesson plan, all of your teachers. So how do you design a simulation? It requires a lot of training. In fact, it's ratified. I'm a member of Society of Simulation and Healthcare. So we have something called CHSE, Certified Simulation Educator. And these are the people, you can do an advanced one. Once you pass the basic one, you do the advanced one. Now we had a computer programmer. So most of the people who run the software and the backend management are called operations specialists. So it is called CHSE OS. And there's a CHSE OS advanced. So you do this. This is a ratified one. It's not yet come to India, but soon it will. I see there is one in Symbiosis, I think, who is CHSE qualified. I'm still appearing for the exam. I had passed a basic one earlier, but then I have to re-ratify it. So I'm appearing that. That's in US. So it's ratified worldwide. So soon, like how we have ACLS, BLS, ATLS for simulation, you'll be having CHSE and CHSE qualified as educators. And it's like a lesson plan. How do you plan your scenario? So there's a whole training given. How do you do this? This is for the educators. And what are your learning outcomes? You have to design them well. These are the part trust trainers. You're a neurosurgeon, you're a cardiac surgeon, you're a cath lab, you got anything, you have to build your team, you can practice everything. Any sort of neurosurgery can be done on this, any sort of, and especially learning ultrasound. The first one shows ultrasound mentors, whether it's bronchoscopy, airway management, any part of your curriculum, you can do by simulation, learn it, and then go back. And the best part of it is, you can do it in your own time, you can practice the skills. This is for skill-based learning. When you're doing, using high-fidelity team-based swimming, that is basically for team building. That you're seeing how a whole team will react in an emergency, disaster, or in the specialized suites, like operation theaters or neurosurgery suite or something. So you can practice all of them in simulation. And that is the advantage, because in very short time, you can get the skill that you desire. So these are the skills that you're actually thinking about. You're looking at the non-technical skills, cognitive, interpersonal, and then whatever, decision-making, task management, team working, situational awareness. I'll not bore you with all these slides because I can see some of them go to sleep. So it's all there. The standard pyramid, everybody knows. Does from the novice to expert. So either he knows how teaching is the best way. If I'm teaching, I learn, I read about the topic because people are going to ask me questions. Then I'm going to do it. And if I'm teaching somebody else, like when I'm training my resident, I have to be better than him. Because if he can't do it or he makes a complication, I have to sort out that. So therefore, it's the learning process in which it happens. And how do you do it? OSCEs, objective structured clinical examinations, and using standardized patients. We make, someone like me can become a standardized patient. In fact, he or she can simulate any condition because I know the condition. I'm a professor. You tell me I become an asthmatic, I'll give you the exact history. I will not talk to you if you don't ask me. So if the student doesn't ask me the right questions, I'll not tell you. Like in one of the simulation examination, we had one of our matrons. She had been given the clue that you'll tell this, but nobody asked her. So in the end, she said, nobody asked me. So you failed in the simulation because that particular thing was not brought out. Sometimes we push in clues as educators. And how do we do this? And this is the cycle. So something, it's a feedback and debriefing tool. Like I told you this, how did it go? Address the comments, learning points, whatever. This is what happens. And the other side is the called learning cycle. And you can actually Google it up because the time constraints, I'll skip this slide. So how do I play this? There's an enter button here, no? Yeah. This is into AR, VR. Yeah. So what I showed you just now was something called immersive simulation using augmented reality, virtual reality, and we're using the Google HoloLens. The one that is shown here is Google HoloLens 2, but I worked with the Google HoloLens 3. So if Google HoloLens 2 is like a 70 screen, the Google HoloLens 3 is like an IMAX screen. So you're actually into it, and actually you can simulate everything in front of you. So I'll show you that again and how it happens. So therefore, this immersive learning is something which is very, very, gives a realistic experience on everything. It is not just some part task trainer or something. And costs are coming down. With the, VR, the costs have come down. Normal HPS costs 6 to 7 crores, one mannequin. Okay, but whereas when you're having AR and VR, the costs are drastically reduced. You have a screen-based laptop, you have the AR suits, you have Google HoloLens all over, and the one mannequin. The costs are 1/5 or 1/10, and costs are coming down because with the Google HoloLens 3 coming into the market very much. So this will be available very shortly in most of the Indian labs also. I think I've already done this standardized patients. We have a 15 years data because the first HPS came about 15 years back in AFMC. The second one came in our Research and Referral Hospital in Delhi. The link is there, Medical Journal, Armed Forces. We have 15 years data on simulation. It's a new toy for all the other corporate hospitals and everyone here. But for us, we have practices for the last 15 years. We have the complete data of the last 15 years. And one more thing is add on to it is audience response systems. When I'm doing a class, I got this in my paramedical school. I'm more worried about the student who's not good. The student who's good, everyone is good. But from the audience response systems, using clickers, using this during simulation, I'm able to, or any sort of an educational exercise, I'm able to make out which student is not doing well. It is very important to use clickers or audience response systems. Second, what are the basic courses that we do? This is any skill lab in the country. Now, most medical colleges and all have these skill labs. This is what we do. Paramedics, nursing students, this is a must know. There are certain 80 skills which everybody must know. And a lot of communication skills, breaking bad news, whether it is doing a glucometer, using a monitor, ambulance simulator, or infusion pumps, multi-para monitors. How do you train them fast? You train them through simulation, doing them actually, having those things there. And this is avoiding medical errors. When you practice, you avoid medical errors. And it's basically using the Swiss cheese model. Someday, everything will go wrong. It's like the Murphy's Law many times over. So what happens is when we're using checklists, when we're using protocols, we end up not making these mistakes. And that is where simulation has a big role. Safety in medical education. A lot of people harp on safety. The right limb, right size, right look alike, sound alike, all those things that we have in medical errors. Most of the aviation industry, I'm also in aviation medicine, I've done some primary and flown. So there we are taught something called attention diversion. We are taught errors due to inattention. There are so many things on errors. Errors itself is a whole topic. So therefore, so this comes into that. And we, as educators, again, we use the Bloom's taxonomy. So in simulation, this makes a big change. If you have to be a simulation educator, you have to know Bloom's taxonomy when you're practicing, when you're making your simulation design. Otherwise, if any simulation center can be a multi-crore place, if you don't have the right type of simulation educators, you'll be a failure in your program. But if you have a good simulation educator and a good team building happening, and you have a good faculty which is there, all your students will be 100%. In AFMC, when any student passes out, BLS, ACLS, ATLS is 100%. And certain must know is 100%. We don't allow him to pass out. They rescrub. before they come back, because the must-know skills are there, because they're thrown all over, everywhere, and they have to perform. So if he's come there and we send him on a ship straight away out on a disaster, I'm sure he'll do well, because he's done the must-know. So that is what is the basic standards that you set. And we don't give US data anymore. We give AIMS, AFMC, NIMHANS, our own symbiosis. We have a repository of data which is better than the West. I have inspected research programs in the US, and my own AFMRC projects, the students would have been thrown out. The US projects were much lesser. Unfortunately, they were a little more professional. They have more money and they are more educative. That is one. I think time. Yeah. Thank you. Yeah, last 5 minutes. So this is something we did. I talked to you about double lumen tubes and all using an ambuscope. We can do this using simulation. So therefore, something very technically difficult can easily be learned in a very short time. This was one paper of mine which we actually did together. This is another thing, a 3D audio visual studio is a must along with the simulation lab. Because these days with the type of videos which are available, it is very difficult to imagine in medical terms what is going to happen. And every time that Cunningham's textbook of anatomy used to be crazy, we used to try to imagine in our mind what is anterior, posterior, this, that, and peritoneum is, reflecting here and there. Sir is there. I think he can share with me certain things. But now it has become very easy because all these videos are available as a repository in your college. And the moment you do that and practice and run it for the students, they'll be more interested in learning what is there. Whether you're learning the eye, the ear, the everything. And it's beautiful in 4K. You must watch the videos. I go back to this 3D sim lab to watch the videos because it makes my anatomy easier. Because I'm an anesthesiologist, I need to know from my regional anesthesia a lot of things. I've learned a lot of things from this. And also screen-based simulation. This is one, we can actually run it. There are a lot of freeware, but you actually do the paid version, they're very good. Something like NSoft, you can actually practice anesthesia on the screen. Then of course, this I've just shown you practicing ultrasound or part task trainers, giving these things. So I'll just run across these. You mostly know them. The HPS, they have a rack and a lot of, you need an operations specialist along with the educator to run this. And what is it? Yes, you have a physical world. Anything you're augmenting here is augmented reality. And you have a digital world. Here, when you move it, it is a virtual reality. What you saw in that video earlier. So in the middle, when you mix them both, you have something called mixed reality to make it like Windows for dummies. For example, I am augmenting my own self with some magnification or with something that I'm augmenting reality. Whereas I already have a CT scan report which is tagged. Now that will become something like a virtual reality which I'm bringing in with my HoloLens and everything. I'm mixing them together. So I'm seeing a real patient's ultrasound. The actual, this is abnormal. Now I'm mixing the normal with the abnormal and it is labeling. This is normal, this is not normal. That is using artificial intelligence, machine learning in reality. So when I'm actually operating, it is telling me where I am. So that is the beauty of this all. So that is where it is, mixed reality, artificial intelligence, also quantum comes into it. For shortage of time, I think this for another day. And I think, can I go back? Yeah, this is how it looks. So what you do is, it comes out in front of you and you do a mixed pinch zoom. That is what you do. This is there. So this is how mixed reality simulation comes in. And I'm sure Dr. Sawant and Dr. Parag will have this shortly. So you'll be able to actually experience it. It is very difficult on your mobile to use your, remember when you first using a mobile, it was very difficult to use touchscreens and all. So this is a little difficult initially when you do this pinch zoom. But in about 2-3 hours, you are able to do it well. So I'll just show you how. So I think, can we just play this? I don't know whether someone's got the... can you mute the volume, please? Just mute the volume. Yeah. So what is happening here is, you're seeing a 3D image. What you have right now is a 2D screen. But you have 3D simulation of this. On one side, you're seeing the 3D image when you're passing a scope. And on this side, you're having, sort of a, ultrasound sono anatomy coming in. So you're learning both at the same time. One is the 3D anatomy and one is the sono anatomy. And so you're seeing a beating heart and you're actually seeing it how it would in virtual reality. And now it is possible to actually do it on the patient and have a background image of what is true. And you can mix them up with a label. What is this? So the operator really knows what he is touching. We do an MRI with what is called glions. And when you do that, like neuro, you are doing it already. Using Neuro Navigator, I'm able to make out where I am. Otherwise, it is actually a skill which is learned by the surgeon, that this is what it is. But whereas I'm an abnormal tissue, now I do it. Now this is one, we already have the ultrasound-based one here in your lab. So this is what happens. You can actually move it out. Remember Gray's Anatomy, where you would move it out from the skeletal, the muscles, the angio, everything. And now I can not only see what is happening in real time on a patient, I can actually, so this is what happens, and I can actually bring it closer to me. I can zoom it. That at the background is the Google HoloLens 3. I can also turn it around. So the moment I use my fingers to do it, I can turn it around to see which valve is bad or what is happening. So this is the advantage of AR, VR, mixed reality, virtual reality and coming into it. So you see this? So this is how it is. I can just bring it back down. And then I concentrate. You can see this. This is me pinch zooming. And this is me trying to turn it on. Correct? So this is very soon going to be available. And all of us, we are going to become better students. We're going to become, trying to do all this all over again. And put it back. So we can actually single out which, like the orthopedic surgeon wants to do something. He can actually just get the bones and do it. Yeah, time up, I guess. So that's it. This is me using the Google HoloLens in Florida. I'm going again in Florida. They called me for another lecture. And so these are my references. There are a lot of books available. And of course, the Navy takes me everywhere. That's the Barren Island volcano. This is where I'm doing scuba diving in Havelock and we're sailing on a ship. This is Andamans where I was last 2 years. Now I'm in Mumbai. Anybody can visit my skills lab. You're welcome. I thank SIHS once again. I hand over my co-chair. Whatever I missed out, I request Madam will do it. And then we'll take on any questions which are there. Thank you so much. Thank you for hearing.
Thank you, sir. I request Ms. Abra Pearl to come on the dais and share her insights on the topic.
Good morning to all of you. On behalf of Indian Nursing Council, I would like to bring you greetings from the President, Vice President, and the whole team from Indian Nursing Council. After listening to Sir, I feel that I'm coming with the starter after the main course actually. It's because Sir has already covered the chunk of simulation with a lot of things, but I'll try to be very simple, going to the basics. And I'll try to turn my starter into a dessert if possible. That's something I would just like to try. Okay, so I would just go through these. This is the outline of my presentation. And what I would like to focus on is what the nursing aspects of simulation. Okay. Before going to the presentation, let me just ask you one question. Is simulation a technology or a technique? Who will answer me, please? Hope this will wake you up. Is simulation a technology or a technique? Yes? It's both. Okay. Many times we tend to think that simulation is technology. For simulation, we need a high fidelity simulator only. And we need so much investment to use simulation in teaching. But from the Indian Nursing Council point of view, as a regulatory body, we think about all the colleges of nursing in the country. So it's a wide gap. You have colleges that are just budding up with a few, with a minimal budget. Then you have very good posh colleges. So how do we balance both? So we would like to strike a balance between both, giving simulation as a methodology first or a technique first, supported by technology. So we go a little other way around, though we know that it's both. But our focus is mainly on simulation as a technique than a technology. So Sir has already shown you this, where fatal accidents happen. And behind every fatal accident, you can see there are more than 600 non-reportable incidents also. So that's huge. So we can see that approximately 1 in 10 patients entering the hospital will suffer harm from these adverse effects. That's the WHO. And the Johns Hopkins study tells that in the US, there are more than 250,000 deaths per year just because of medical errors. And a Harvard study by Professor Jha in India, they say that 5.2 million medical errors are happening in India annually. That's a huge number. So we try to reduce them. So why do we need simulation? Okay, when the concept of simulation came in first, so there were many oppositions coming up. People were telling, we have a good clinical facility. We have so many patients. Why do we need a lab? Okay. When we have a good facility, when we have a good clinical facility where patients are cooperative and we're big institutions, so they were opposing it. But why do we actually need simulation? It's because of the student-patient ratio and the decreased length of stay in the hospital. Previously, we used to have people staying for a long time, but now we talk about ambulatory care and all. So the length of stay is decreased. Limited clinical sites again. There are so many colleges. We need to produce so many nurses. in a short span of time. So that's a problem. Faculty shortage. There's a lot of migration in nursing, if you see. A lot of people complete their course, move away to other countries, so faculty shortage. Patient safety initiatives. It's not like olden days where patients listen to all that you say. But now it's the other way around. We need to be more focused on the patient-centered care. Medico-legal issues are coming up and cultural change is also happening. Previously, if you, when I was a student, I can remember I did my undergraduate in Madras Medical College. So we had Humpty number of patients in the injection OP, they'll be lined up. You can give any number of injections. But now the scenario is not like that. Before giving each injection, for each patient, we have to explain to them, get their consent. But I don't remember doing that 20 years back. So that's a difference. There's a lot of change in the field. So why simulation now? So training in simulation environment is an additional step in the learning process, a step between classroom instruction and actual clinical instruction with real patients. So it's between, it's additional. It's not a replacement. Many times we think once simulation comes in, clinical practice need not happen. No, it's a bridge that bridges the gap between theoretical learning and clinical practice. So I'll also just like to highlight the challenges of clinical teaching. Students are exposed to live patients. Now we talk about infection and all with masks. So how do we see the expression of patients? So that's a problem. Then we are concerned about patient safety, and the clinical instructor's role is very dicey there. She has to manage the students as well as see for the patient safety also. And instructors are committed to protect the patients. Making mistake is an expected and inevitable part of the learning process. But mistakes are a real risk to patient safety. So we cannot take risks in a clinical situation. So coming to what is simulation? So I already told you, we look at it as a technique first and then a technology, as a methodology first and then as a technology. So it's artificial representation of complex real-world processes with sufficient fidelity, which aim to facilitate learning through immersion, reflection, feedback, and practice, minus the risk that is inherent in a similar real life experience. And we talk about experiential learning here. Sir has highlighted many things, how experience, immersion is important in simulation learning. Let me just highlight to you on the circle of learning. So this is the circle of learning, the framework where we can identify all these 5 aspects. So there should be knowledge acquisition first. So that should happen with all the theoretical aspects. Then there should be skill proficiency. So was talking about task trainers. So skills should be proficient, and decision-making skill is very important. So even we have the knowledge and we have the skill, but we don't know when to apply it and what to apply. That's a problem. So this is a very important step in simulation, in the circle of learning. And then comes simulation in teams. So with the knowledge and the skill proficiency, we take the right decision and work as teams, and finally going for clinical experience. So this is the whole circle of learning where simulation fits in. Yeah, so here you can just see how simulation fits in the circle of learning. So it's a teaching strategy. It's also an evaluation tool. It provides more experiential learning opportunity than instruction. And there's use of learning technology. There's emphasis on outcome-based education and implementation of evidence-based educational strategies. So simulation focuses on all these things. So this is a slide that shows how competency development and maintenance happens. So when a person comes in for a simulation training, usually they are unconsciously incompetent. They think they know everything. So this is what we experience in our simulation lab. That's what they think they know. So we just do a pre-simulation scenario, a pre-test kind of thing. Then they are aware of where they stand because they have been into clinical practice for a long time. They think they are proficient, but when we do it as per the protocol, something is missing. So awareness comes. So then they go in for learning because after this they become consciously incompetent. They know that something is missing. They go in for learning, and once they learn, they become consciously competent, and then they do practice. So once they do practice, they become unconsciously competent. That is the proficiency level. But and when they are unconsciously competent, there's a problem because if they are rusty, they lose interest, they again go into this step. Simulation fits everywhere here. So you can do a pretest to know that they are to stimulate their awareness. You can teach, you can practice, and you can maintain the competency also using simulation. Now, what is the paradigm shift? Previously, we were talking about see one, do one, teach one. And if we are able to teach one, that means we are proficient. But now we talk about see one, practice many, and do one. Okay, so we cannot just do one. We have to practice many before we do one. Yeah. So what's the evidence? So this is a study by National Council for Board of Nursing in 2015, which says that 50% of the traditional clinical hours in the nursing curriculum can be replaced by simulation. Similar study is being conducted by the Indian Nursing Council. We are awaiting the results. Once the results are out, we'll know how much percent in the Indian context can be taken up by the simulation instead of the traditional clinical hours. So this is another graph just showing about the proficiency. So if you see, if we have just a single training, initially after the training, the proficiency is high, but as years pass by, it goes down. Then another training is needed to build it up, and then again it goes down. But when we have a simulation lab adjacent to the clinical area, or as in the college where it's free to be used, they can have different sets of trainings so the proficiency can be maintained. So simulation is not only in pre-service education, simulation is important in in-service education also so that proficiency can be maintained. So what are the benefits? Just summarizing what Sir has already told. There's patient safety, there's better preparation for new nurses, their support, innovative teaching strategies can be used. Nowadays, a major challenge for all faculty is how to make the students sit in the classroom because they are not interested in sitting in the classroom. They many times they are physically present, but they are not concentrating. So a lot of things occur nowadays. The Gen Z are quite different. So this is a very good teaching strategy to capture the attention of students so that they will really be interested and motivated to learn. And we can adhere to protocols using simulation. Okay, because many times I know faculty will face this challenge. When you go to a different institution for examination, or from when you have a faculty external examiner from a different institution, they will tell you, this is not how it should be done. Why do you start from there to here? We go from here to there. Then there's a big controversy. But in simulation, we talk about protocols, and if the protocols are standardized, it's uniform. So everyone can use the same. We don't have that confusion and that problem. Then overcome faculty and preceptor shortages and lack of clinical sites. So practically, some places are facing this problem, and that can be addressed here. And it provides opportunity to practice and acquire clinical skills which cannot be done during the clinical training. CPR cannot be done during a clinical training. And any emergency management like eclampsia management or obstetric shock, it cannot be done, PPH, cannot be done in an actual scenario, clinical setting. So this can be done in a simulated area. And it prepares students to provide safe and quality services. Benefits, that non-threatening environment is there. Then hands-on practice of the critical life-saving skills without risk. Teaching of clinical skills is there, and teamwork. So very clearly stressed on teamwork, because multidisciplinary, everyone should work on. So this is very important, and debriefing at the end of the simulation is the key for the whole process of simulation. So here you can see the advantages. These are pictures from the National Reference Simulation Center, which is developed by INC. I'll be just telling you about that. So this we have already covered. So this is, in a nutshell, giving the structure of simulation. So you have pre-briefing and the scenario, which gives experiential learning. So the students are given a pre-brief, the scenario, then they run through the scenario, they actually work it out. So they get the experience here, and then they come for debriefing here. And during debriefing, reflective learning takes place. So both experiential learning and reflective learning can be combinedly used in simulation-based learning. And what happens in reflective learning? There are reactions, immediate reactions that are analyzed. Then the analysis phase, where Sir actually explained that they'll be talking about what went wrong, what went well, why it went wrong, why it went well, what can be done differently. So all these happens here. And then finally, there is summary of the whole simulation scenario. So with this, the simulation process is over. And if there are any observations, the whole process can be repeated for better clarity. So repeated drills can be done using a simulation scenario. So coming to what's happening at the national level. So the National Reference Simulation Center was established in 2018, and it is at SGT University, Gurugram. So there we have high, medium and low fidelity simulators, and the partners who established this are INC, JAPICO, Lateral and SGT University together at partnership. And this is a picture of our simulation training. It looks a little different maybe. This is not a high fidelity simulator. It's a Mama Natali, through which we teach normal delivery, the process of normal delivery, where a person acts as or simulates as a mother, and the whole process is carried out. So this is one of our pictures from our trainings. And then why did this come up? So it is to generate evidence and to integrate simulation into the nursing curriculum, and the possibility of international collaboration with technology intervention. So that's the aim. This, we are doing it now. This has been achieved now. These are some glimpses from our simulation lab. So this is the task training area. This is the CPR room here again. So, yeah. So we would like to see a simulation like this, where a person, this is a delivery, normal delivery simulation scenario. So this is what we would like to see. So in the nursing curriculum, I told it's already achieved. So the BSc nursing curriculum has been recently revised, and many universities have started implementing this year, and many will be implementing next year. That is 22-23, they'll be implementing. And simulation-based education, experiential learning, they are incorporated as teaching methodology into the curriculum. And it is mandatory now for each College of Nursing to have a skills or a simulation lab. The mannequin list is developed by the Indian Nursing Council, and it is shared. And again, it's not the high end what we are looking for, but the basics which are necessary for a simulation lab is present there. And specific hours for skills lab are also mentioned in the curriculum, and 30% of the procedures can be signed off by simulation itself. So that's a liberal liberty that's given to the teachers for the usage of simulation lab. Previously it was, though they use in simulation, they have to do it in the clinicals to get their logbook signed off. Now it is 30%. And OSCE is a mandatory method of evaluation for clinical skills. So that's another thing that has been taken care of. Then the role of INC in promoting simulation-based education. So Indian Nursing Council has included this in the BSc Nursing curriculum. National Reference Simulation Center has been established and faculty are being oriented through the simulation-based education. So INC is conducting a 6-day training for all faculty. So colleges are sponsoring them. One faculty from each institution is sponsored by the INC itself. It's a 6-day training. So, so far we have trained around 200 nurses. The target is 1,000 because it's wide. So that's happening. And there's another training for midwifery faculty where skill training in midwifery is given along with simulation-based education. That's 5 days. That again, INC sponsors one faculty. So the target is like one person from each institution for simulation-based education, one person from each institution for midwifery. So we'll have at least two people from an institution who is trained with this methodology. So that's the target. Indian Nursing Council is also providing technical support to the ministry for the establishment of regional skills centers, simulation centers. So this is what INC is doing at the national level. So coming to summing up the whole thing, so simulation training helps to prepare students to deal with unanticipated medical errors, to develop teamwork and communication skills, to increase confidence, and to improve performance. So it prepares students for their future career and enhances maintenance of proficiency through repeated skill practice and drills. So when we see from the previous or traditional method of education, simulation is quite different because there's more of student-centered learning, it's more of competency-based learning and more of experiential and reflective learning. And it has been proved that it is very important for the present healthcare simulation education so that the people will be really trained to handle emergencies also. Okay, so I conclude telling simulation is the need of the hour in healthcare. And before I tell thank you, may I just tell a short story to all of you. Okay, maybe you might have heard it, but for the benefit of those who have not heard, let me just tell you this. Okay, it was a warm morning. A small boy was walking on a beach. Okay, so he was just walking on the beach. He saw a lot of starfishes on the beach which were washed because of the evening tide. So playfully he started picking them up and throwing them into the sea. So he was doing it as a fun activity. There was an old man who came there for his morning walk. So he saw this boy and he was looking at him for some time. So then he wanted to just provoke this boy. So he went near the small boy and asked, "Son, what are you doing?" So he told, "I'm just putting the starfishes back into the sea." And then suddenly something clicked his mind and told, "I'm saving them." So he told that. Then this man told, "Do you really think you can save them? See, thousands of starfishes are lying down around on the beach. If the sun comes up, all of it would die. Do you really think of saving all of them?" So this boy didn't expect that. So quietly he was just looking at the man. He didn't know what to say. He bent down, picked up one starfish and flung it right into the sea and said, "Sir, I may not be able to save all the starfishes, but for this one, I have made a difference." So for this one, I have made a difference. All of us sitting here are somewhere related to healthcare. Okay, many times nowadays we talk more about technology, we talk more about health economics, and finally we miss out on the human aspect of care, which is very important. Do we as healthcare professionals or a team of multidisciplinary professionals linked to healthcare, are we really caring for that person who comes in, not as a case, not as a patient, not as bed number, but as an individual who comes to us in need? So if we can touch the life of one person in our career at least, then there's meaning for our life and we can make a difference. If all of us sitting here can decide to see our patients as individuals, and if we can work for it, surely all these technology will be a boon, will be a support for us as we provide quality care for our patients. So with that, I thank all the organizers for giving this opportunity. So we'll be taking care.
You can see how two is better than one, and team building, helps, and Madam has really been a nice result. I think there's a round of applause for the thing. And if you take on the questions, we have to answer your questions. Thank you.
I would like to have a little bit more clarity on simulated patients and standardized patients. What is the difference between simulated and standardized?
See, standardized patients are real humans who have got the knowledge and they are briefed on what role play they are supposed to do. So that is what happens is there's a mix and match. Whereas a simulated patient is, it's a ST, what the standard acronym is for a standardized patient. Now, standardized patients are used worldwide. In this case, what happens is he or she is playing the role of that particular patient. It may be an asthmatic, it may be somebody with cardiovascular disease somewhere. So most of the history taking and all these skills can be taught using a standardized patient. And since this person knows, he may be a doctor or a nurse who actually can simulate or say the right things and have a big knowledge, you can actually replicate what that case would be like. Most of the time, standardized patients are used for history taking and these skills, and they are also taken for rare patients. You could actually have moulages and all and make it look like that. So, what happens is learning a rare disease, for example. So, this person, like I know exactly what some sort of thalassemia minor or something what patient would give and what history they would give. So, this way, it is one-to-one experience. That is the advantage of the standardized patient. Now, when you say simulated patient, it may not, you could have a knowledge. That could be a simulated and you just told what to do. That's all. That would be the difference. I mean, anything Madam has to add, can do that.
So let's explain, but what we in our institution are doing is, when a person is acting, maybe a student, or maybe sometimes we use our office helpers also, and we train them and make them sit there as a patient. We call them a standardized patient. When a person is wearing a simulator, like a mama birthday, she's wearing it on herself, and then she performs the role of a mother who's delivering. Then we call her a simulated patient. Terminologies vary with institutions, but this is how we are doing. So if it is a person alone, like for history taking her, we call them a standardized patient. But when she wears a simulator on her, or not a simulator, it's a low fidelity, it's a wearable. Right? So when she's wearing it and she goes back, we can try history from her also. Same thing we can deliver also. So that time we call her as a simulated patient. That's how we do.
I have a question for you. I have a lot of respect for the nursing profession, but when you put up that slide about maintenance of skill proficiency and the x-axis showed a duration of a few years, 4 years, I rub my eyes to almost disbelief. I'm working in a community hospital in Mumbai, and to have any nurse in the hospital for over 4 years is like a miracle. Madam, can you help us in reducing the attrition rate in our healthcare with the nursing profession? That's our biggest challenge we have over here. So before you simulate, you teach them the next batch is there. I'm making a point to try and learn nurses' names from what I work at. But before I can even get their names, they're gone. So how is it that we can have our nurses stay with us for anything longer?
This is a challenging question. But that graph that I showed is not only for nursing, it applies to all health professions, I suppose. And how to retain nurses? That's a real question. I would think why nurses are moving. Actually, we have a session tomorrow which will be taken by our president. But just because of the question, I just give one or two reasons why nurses are moving from India. We have a lot of nurses who migrate to other countries. First thing, I think, status. Because many times, though we talk about equality, though we talk about nursing as an autonomous profession, we are all mostly considered as paramedicals. though it is not. Some will ask me why. You have to do some googling and you find out why. So that is one reason. And the next one is job satisfaction. We do something, but are we really getting the reward or at least a recognition for what we do? So that is the reason why nurses are not still. Economic, that's there. But a person who is satisfied with the job will stay.
Just an extension of what she was asking. Our usual experience has been that with the lowering of entry barriers over maybe the last 20-30 years, what we have seen is you also talked about so many
Say thank you,
the Harvard
say
study
thank
which
you.
you quoted where
No, these people
million
are there, no?
medical errors are reported from India.
Say thank you to
Now,
both of them.
one of the major factors probably is that the caregivers who are there with the patient all the time, somewhere we see a lack of skills, and that is probably not just limited to what is being in the curriculum, but their ability to grasp the that much of a education. So probably a lowering of entry barriers was not such a good idea. The second aspect is like the brain drain which we are talking about. Now, for doctors, the government has implemented, they have banned issuing of NORI, that is no objection to return to India. That is no longer being issued, so none of the doctors can go permanently abroad. Now, is there something similar which can be done for nurses going abroad? And why not?
So for your first part, I agree that the quality has reduced. I will not say no to it. As the entry where it has been reduced, the quality has reduced. The problem was, talking from INC's point of view, many times we have targets, like this many nurses should come up within this many time. So what do we do? So all those political factors also are there. But I think if all the faculty are trained, wherever they are, they will be able to train the students to be better nurses. So my answer to that is, if the faculty is really motivated, if the faculty thinks she can do, she will be able to bring about change. So that's one thing. And the second question, I don't think I have the answer for it. I should ask Sir when he comes.
I'll just add to that. It's actually your self-motivation and the passion to one's career which drives in the entire healthcare profession. So, yeah, because this is what keeps us in, not economic factor. So most of the people who join medical, nursing and paramedical, they are devoted to their patients. Let me put it very straight. Regarding the second part, I think it's an introspection to see why you are asking only the healthcare doctors, nurses who have all these rules and regulations come back. Why do we ask the software professionals, engineers and lawyers who want to have all of these questions? Why don't we ask the software engineers and Google to come back? Why don't we ask the lawyers to come back? Why don't we ask the MBA guys to come back? So I think there's an introspection we need to do here. Thank you.
Thank you all. It was a great honor to have you all attentive and tuned in. I now request Dr. Parag, Director of Symbiosis Center for Health and Skill, to felicitate Dr. Manish Honwad and Mrs. Abra Pearl. Say thank you.
Okay, we have second round. Thank you everybody for being a very nice patient audience. Thank you, SYMHEALTH.
Thank you, Dr. Parag. Thank you, sir. Thank you, ma'am. Ladies and gentlemen, as a health promoting university, we now have a short activity break. I welcome Mr. Krishna from Department of Sports, Recreation and Wellness to take over.
I request everyone to take a part in this activity. Before we start with the activity, I'll just tell you a few actions, movement that we want to do with this song. This song is basically action song. We are going to do it. Okay, before we start, just see there are 4 to 5 actions which we have to do. The first song action is like this, like this. The second action is like this, like this. The third action is knocking on the door, knocking on the door. Okay, the third action. The fourth action is polish your shoe and polish your shoe. This is the fourth action that we are going to do. Okay, I request you to please stand up. This is 2 minutes activity break. Everyone please.
Social media platforms, that is Facebook page, Instagram and LinkedIn. Don't forget to tag us and use the hashtag SYMHEALTH2022 in all caps. Thank you.